Hi, this is Dr. Shanmugham. I am a neurologist and assistant professor of neurology at UCF School of Medicine. Today I want to give you an overview of a neurological examination on how to do it quickly, efficiently, and get the diagnosis. I want you to organize your thought process from head to toe. First, start with higher cortical function. I want you to do the mental status examination and language examination. To do the mental status examination, you can do a standard battery like Montreal Cognitive Assessment, or you can ask the patient to say the date, day, month, and year. If patient is able to say it correctly, then the mental status examination is probably normal. If they are not able to say it correctly, instruct them on correct day, date, month, and year, and ask them to repeat it a few minutes later. If they're able to repeat it correctly, again, mental status examination is probably normal. If they're not able to repeat, then that is a sign of cognitive dysfunction, where you may want to do a more extended assessment of mental status. Language function is assessed in 5 parts. Number 1, verbal output. See how the patient is able to communicate with you. Then assess the comprehension. You want to look at 1-step, 2-step, and 3-step directions the patient able to follow. Ask the patient to repeat. Again, a word, phrase, and a sentence should be repeated. Then you want to assess naming. Again, start with the simple objects like a pen, tie, comb, etc. Once the patient gets it correct, ask them to name more complicated parts like knot of the tie, cap of the pen, type of things. Then assess reading and writing. Ask the patient to read a paragraph or a sentence. I usually write down, please close your eyes, and then ask the patient to read it and then follow the directions. Writing, again, ask the patient to write his own sentence and see how well he completes it. The sentence should have object, subject, verb, noun, and all those things to be complete. Once you're concluded with the higher cortical function, then move on to cranial nerve examination. Again, your examination is guided by your history. If some parts of history indicates that an examination will be normal, then you can easily skip it. When you're checking 12 pairs of cranial nerves, most of the time you do not examine olfactory nerve because it does not have great localizing function. When you start with the cranial nerve 2, I want you to assess visual acuity, visual field, and fundoscopic examination. To do the visual acuity, you can use finger counting or use a Snellen's chart. When you're doing the visual field examination, first assess the central field. Ask the patient to look at your face and see whether any part of your face is missing. Then do the confrontation examination, where you're comparing your visual field to the patient's visual field. You want to do the superior, inferior, temporal, and nasal visual fields. Fundoscopic examination, again, mainly look at the appearance of the retina and fundi, mainly looking for any abnormal vasculature or papilledema. Then we go to 3rd, 4th, and 6th nerves, which involves examining external ocular movements and look for any abnormal movements of the eye and diplopia. When you're looking for movements of the eye, you want to check it in the neutral gaze and also in the secondary gaze. You want the patient to look to the right, look to the left, right, up and down in lateral gaze. And then you look for any evidence of nystagmus and then diplopia in the right and left gaze. Then we move on to fifth nerve, mainly assessing the sensation in the face involving V1, V2, and V3 distribution of the trigeminal nerve. I want you to check light touch and pinprick sensation. Use a tissue paper to touch the face to see whether the patient feels it, and then you can use a pin to test the pain sensation in the face. Again, you're checking it in the V1, V2, and V3 distribution. Sometimes you may also want to examine corneal sensation by touching the cornea with a piece of tissue. Again, your examination should be guided by your history. Then we move on to seventh nerve, facial nerve. You're mainly looking at the muscles of facial expression, frontalis, orbicularis oculi, nasalis, orbicularis oris, mentalis, and platysma. And you want to see whether they are moving symmetrically and the upper half of the face is moving as well as the lower half of the face. Then we move on to vestibulocochlear nerve. We only examine cochlear nerve with a tuning fork using a 256 hertz tuning fork. I want you to do Rinne's and Weber's test. Rinne's test is, again, you're comparing air conduction to the bone conduction in each ear. You check the vibration close to the ear and then compare it to hearing on the mastoid bone. If air conduction is better than the bone conduction, that is normal. Weber's test is done by putting the tuning fork in the forehead. Ask the patient whether they hear it equally on both ears. If one side is impaired, then other side is stronger. Stronger side is the normal side where the bone conduction is stronger. Then we do vagal and glossopharyngeal nerves, mainly looking at the midline position of the uvula and the movement of the soft palate on each side. If uvula is in midline, that is normal. When you ask them to make a sound ah, please observe which way the soft palate is moving. Whichever is siding moving better is normal. The side that is not moving is weaker and abnormal. You can also check the vagus and glossopharyngeal by doing gag reflex. Take a tongue blade, touch the back of the throat on each side. A robust response is normal. If the response is decreased, that is abnormal. Then we go to accessory nerve. Most of the examiners will do trapezius examination by shrugging the shoulder to test the accessory nerve. I also want you to examine sternocleidomastoid because you may see weakness in the sternocleidomastoid very early on in neuromuscular diseases. Ask the patient to push your hand with their head and see whether they can resist your force in head flexion. And then the 12th nerve, hypoglossal nerve, ask the patient to protrude the tongue and move it side to side. When the patient protrudes the tongue, if it deviates to one side, the side it is deviating is the abnormal side. Because the hypoglossal is weak on that side, it is not able to push the tongue to the other side. So the stronger side pushes it to the weaker side. This is the conclusion of cranial nerve exam. Then we'll do the motor examination. Motor examination involves testing the muscle strength, muscle tone, and any abnormal movements in the extremities and muscles. I always use a 5-point scale from 0 to 5, where 0 is no movement in the muscle, 1 is a flicker of the movement. 2 is movement is present when gravity is eliminated. 3 is against gravity. 4 is against resistance. 5 is normal. When you're doing the motor examination, you can organize it in a proximal to distal examination, or you can do it in a myotomal distribution. When you're doing the motor examination, and also look for any abnormal movements like tremors in the hands, and you also want to do the tone examination, which is easier to do in the upper extremities. You always have to move the extremities in 2 joints to appreciate the tone. In the lower extremities, it is difficult to assess the tone. You have to drop the foot or the leg by holding at the knee. If it drops smoothly, it's normal tone. If it has a ratcheting movement, then it is abnormal tone. Once you complete the motor examination, then we'll move on to sensory examination. Here we are mainly examining posterior column and the spinothalamic tract. To examine the spinothalamic tract, you need to assess the pain sensation and temperature sense. Use a pin to test the pain sensation. Again, you can use it proximal versus distal or dermatomal distribution. If you're suspecting a peripheral nerve pathology or a radicular pathology, then you will have to examine the sensation in the peripheral nerve distribution or the dermatomal distribution. To examine the posterior column, use the tuning fork, which is 128 Hertz in frequency. Examine the vibration in joints, in the distal phalangeal joints or in your toe. Again, you can do it from distal to proximal and see whether there is any difference. You can also use position sense to examine the posterior column. Again, do it in the joints, move the joint up, down, or sideways, and ask the patient to identify it. In some occasions, testing cortical sensation is also helpful. Cortical sensation is tested by using stereognosis, 2-point discrimination, and extinction. To test the stereognosis, give different coins like a dime, nickel, and a quarter, and ask the patient to identify with their hands with eyes closed. You can also use 2 sharp points to test the 2-point discrimination, especially in the fingers. To test the extinction, you do the 2-point discrimination, touch the patient on left side, right side, and both sides, and see whether the patient can identify which side or both sides you're touching. Then we move on to cerebellar examination, where you're examining cerebellar hemispheres and also midline cerebellar function by examining the vermis. Finger to nose examination is mainly testing the cerebellar hemispheres. Heel to shin examination also does the same thing. To test the vermis, you will have to do the gait and station examination, ask the patient to walk, do the Romberg examination or Romberg test, and ask the patient to walk in a straight line to test the tandem walking. You can also test the rapid alternating movements to test the cerebellum. Once the cerebellar examination is over, we'll do the reflex examination, which primarily consists of doing the deep tendon reflexes. Use a good quality knee hammer to elicit the reflexes. You're examining biceps, triceps, brachioradialis, knee and ankle reflexes. I grade the reflexes from 0 to 4, 0 being absent reflexes, 1 is diminished reflex, 2 is normal, 3 is hyperreflexia, 4 is clonus. When you're doing the deep tendon reflexes, sometimes it's also helpful to do the jaw jerk, which sometimes may be abnormal in bulbar pathology. You also have to examine pathological reflexes. The number 1 is Babinski. Always pay attention to the big toe. Dorsiflexion of the big toe is pathological. Again, start at the edge of the lateral edge of the foot and go along the ball of the toes to examine the Babinski reflex. Sometimes doing abdominal reflex, cremasteric reflex, and bulbocavernous reflex is also helpful in assessing spinal cord pathology. As a part of the neurological examination, always auscultate the heart and auscultate the neck to listen for any murmurs or bruits that may indicate carotid or cardiac pathology, which may be responsible for CNS pathology. So this concludes our overview of neurological examination. Thank you.